My name is Dr. David Maddy, and I teach at the University of Louisville School of Dentistry. And this is a mini series of lectures that I created designed for dental students that I title Functional Occlusion and Advanced Restorative Concepts. Most of the content of this mini series comes from a book written by Dr. Peter Dawson titled Functional Occlusion From TMJ to Smile Design. There will be some references from a book written by Dr. Occlusion titled Management of Temporal Mandibular Disorders and Occlusion, and there are several animations throughout this mini-series by ByteFX that help illustrate three-dimensionally the complexities that are involved. And there is an icon in each appropriate slide that has a reference from one of these sites. This is the 7th lecture in the series that I title The Magic of Plastic Occlusal Splints. Last lecture, we categorized our patients into green, yellow, and red, with the green, meaning to go, were patients that had no signs of occlusal instability, and so there would not be concern and treatment could be made within their regular MIP without regard to condylar position. Then there were the red patients, which are going to mean stop. And in those people, there's internal derangements of the disc itself or a damage maybe of the medial pole. And on those people, we want to stop and treat the joint first. And then when that is fully treated and healed, then we want to treat the occlusion. But we'll find that most patients are in the yellow category. And these people have signs of instability with wear, mobility, migration, maybe sore muscles. Then we spoke of 4 major options or combinations of in treating the yellow, because the goal of the yellow is to treat the occlusion. We treat the occlusion by creating a perfected occlusion within these patients. We could reshape with equilibration. We can move the teeth, reposition with orthodontics. We can restore through reconstruction, restorative dentistry. We can move bone through orthodontic surgery. These are more of the permanent, long-term resolutions. But there is a 5th option, and that would be to create a splint, make a splint in their mouth. And think of this as a short-term option, or maybe a temporary option, or sometimes a longer term, depending upon the conditions, we'll cover a little bit later as this lecture continues. An occlusal splint, sometimes known as just splint, night guard, Michigan splint, is a removable dental appliance that covers one or both arches and is designed to manage forces to protect and stabilize the teeth and the supporting hard and soft tissues of the masticatory system. Now notice I said manage forces to protect and stabilize. See, if we think of the masticatory system being composed of harmony and balance between the teeth, muscles, and joint, there are times that it is not in balance, and a splint can be used to manage these forces. If you remember, we spoke of, in Dr. Cranon particularly, that occlusion is about force management. And most often, it's made of acrylic, it's made by a dental lab, and it's made on the maxillary arch. It's an example of what a typical maxillary full occlusal splint might look like. And then we spoke in this series in great detail about a perfected occlusion, and we said, do people have it? And we said no, and then we said, why talk about it? And then I gave you examples of when you might want to include this concept of a perfected occlusion into the masticatory system. And you'll see that splint construction is listed because it's stable, it's protective, it's comfortable, and it's predictable. The construction goal of an occlusal splint, is to create a perfected occlusion. And we want to do that with 3 requirements. We want to make sure the condyle is positioned in centric relation. We want to create stable, equal intensity centric stops on all the teeth while the condyle is in centric relation. And hence, CR, CO, and MI are all the same. Then we want to create anterior guidance that has immediate separation of all posterior teeth. This video animation will walk us through how a full occlusal splint works by creating a perfected occlusion. This patient, or this diagram, has a CO-MI discrepancy. Notice the condyle is not seated while the teeth are in contact. There's generalized muscle incoordination, spastic muscles. Now, lateral pterygoid cannot relax because that lateral pterygoid is always in function holding the jaw forward so the teeth can have final closure in MIP. Let's walk through the 3 requirements. We have spastic muscles. Condyle cannot seat. When we make the splint, we want to make sure that we make it and then adjust it so that when contact occurs, the condyle is completely seated. And hence, we see that lateral pterygoid starts to relax. Then, we want to make sure that when we rotate into full closure, there's stable, equal intensity stops on all teeth. And that as soon as there is any movement out of full closure, we have immediate separation of all posterior teeth, hence shutting off elevator muscles, managing forces. Here is a lab project that we have our students do in their preclinical occlusion and TMD class so that they can learn how to adjust a splint. These are additive printed splints that are all identical, and they're mounted on identical models, so all students have the same conditions. Notice that the contact points are all pretty much the same in equal size and intensity, and that the posterior ones are touching the opposing mandibular buccal cusps, and the anterior ones are touching the incisal edges. Then we have them adjust out the occlusion, so when they go to the right or the left, they're only on canine, and when they go forward, they share it in the anterior area. And notice that there is no green contact in the posterior, which means that they have adjusted it with immediate posterior disclusion. When I got out of school years ago, I had no idea how many splints I'd be making or what would be reasons for making splints. So I'm going to talk with you about 6 reasons for splint construction. Of course, the first is to protect the teeth from parafunction. And we don't want to wait till we're at this point because nobody wants to be a nub, and this is kind of late for protecting teeth. We want to find these things earlier and sooner. And so it works by most parafunction occurs while sleeping without the patient being aware. When the splint's in the mouth, the maxillary teeth can't wear. The mandibular teeth are bruxing or grinding against plastic, hence saving tooth surfaces. Another way would be to protect the investment of anterior restorations. You don't want to have this come in, it'll ruin your day. And if you've done a large construction and you've put that patient into the best, most balanced occlusion, or that condyle seated with immediate posterior disclusion, you still at times feel like you want to protect it. And it works by parafunction occurs while sleeping without the patient's awareness. When the splint's in the mouth, the maxillary teeth will not have excessive forces, and the mandibular teeth will be bruxing against plastic and not a hard surface like porcelain. Now, often these people that you end up doing this large type of dental restorative work to have had a history of parafunction and destruction. And so making them a splint might be wise. You can use it to treat acute episodes of TMD pain. Acute TMD pain is almost always a muscle in origin. If the disc is involved, either displacement or dislocation, there'll still be a muscle component because the lateral pterygoid attaches to the disc. So by creating a perfected occlusion on the splint, you'll shut down the excessive muscle activity allowing healing to occur and pain to resolve. You can use it to manage chronic temporal muscle headaches or chronic orofacial pain. Chronic temporal muscle headaches are often the result of temporalis muscle overuse, spastic muscles, often occurring from nighttime nocturnal parafunction. So creating a perfected occlusion on the splint will shut down the excessive muscle activity, allowing healing to occur and pain to resolve. Post-orthodontic retention. Many years ago when I graduated, it was common for an orthodontist to make what's called a Holly appliance retention. And these appliances kept the teeth from moving but did not interfere with the occlusion. But then during that 30 some odd years that I practiced, there became a time when I started seeing more of what was called an Essex retainer. And this is just a thin covering of plastic that covers all the teeth. And it does interfere with the seating of the condyle while the teeth are closed into occlusion. And so making a splint for a post-ortho patient, and if they wear it every night, it'll keep the maxillary teeth from moving. And creating the perfected occlusion on the splint will manage excessive forces, keeping the mastoid core system calm and stable. And then if you couple that with a lingual bar that goes on the canine to canine in the mandibular area to keep the anterior lower teeth from moving, then you have yourself a good orthodontic protective design. And finally, post-periodontal treatment, occlusal force stability. If you look at the diagram on the right, you'll see that the contact down the long axis doesn't create mobile teeth. But if they're hitting on inclines, you'll see the teeth have a preponderance to create mobility, which affects long-term periodontal stability. And so a perfected occlusion is adjusted into the splint, and that'll direct the forces down the long axis of the teeth. And there'll be no lateral destructive forces that can potentiate periodontal breakdown. Splint construction sequence. You want to start by taking excellent impressions of both arches, and you can use either Algin or PVS. But PVS is a little more accurate and can sit around before you pour it, so you might consider that. You want to use a full-size articulator with facebow maxillary cast mountings. You want to take a centric relation intraoral record to relate the two casts against each other. And an easy way to master is to use what's called a leaf gauge with PVS bite material. You need to instruct the dental lab on the construction goals and educate if necessary. Don't assume that they know. See, it's common that the dental lab will have never seen a centric relation intraoral record mounting because they do all their work in MIP when they do their crowns and their partials. And for them to see that mounting, they might think it's wrong because it hits in the first and the anterior is open. So you have to educate them and help them understand that that really is the way you want it and it is correct. And then you want to deliver in the mouth, constantly verifying that you're still in centric relation position by using bimanual manipulation. Sometimes, though, it's hard to get that centric relation intraoral record with accuracy because those muscles have been spastic and that lateral pterygoid just isn't letting go, allowing that condyle to go into the most seated position. So at times it has value to create an anterior deprogrammer where it only touches in the front, opening so the bacteria teeth cannot have contact. And sometimes you just use it for a little bit in the office, maybe 10 or 15 minutes. Sometimes you might have to send the patient home with it. And, you don't want to use this for short term, maybe a couple days. And you can use it as a diagnostic device as well. If the pain goes away, then it's often just muscle, and that's a good indication. If the pain gets worse, then it might indicate that the disc is displaced and that the condyle is going into the retrodiscal tissue. But out in the real world, I used to see many inherent problems with most delivered splints. They're just really not adjusted in the mouth with a perfected occlusion. The condyle would not be in CR. There's many contacts missing. Contacts would be too large. The contacts are not even in intensity. The anterior guidance would not be adjusted with immediate posterior separation. And commonly, the splints just didn't see completely. Now, see, you can see through the splint. It's clear, and you can see if it's going up all the way. And often you'll see that it won't. It might go better on the right side than the left side. And if it does that, well, then, immediately the occlusion's got to be off from the way the lab made it. And often you'll find they weren't even adjusted. A couple years ago at school, we shifted our parafunctional splints to use a material called clear astron. It's still a hard plastic, but it has a thermoplastic ability that gives when heated. So we have them put it in a water bath for 160 degrees before they seat it. And then we have them ask the patients to close firmly. And since then, we're finding very, very few splints that don't seat completely all the way up. Very wonderful material. Now, there are some splints that are probably not best to use. We have one called a posterior pivot appliance. And these are designed so only contact is present on the posterior teeth. And the idea was they would claim that by opening like this, you would be unloading the joint. But in reality, you're really loading the joint. Because if you remember, as long as the elevator muscles are allowed, as long as the posterior teeth are in contact, then the elevator muscles have the ability to have maximum contractibility. And so with this device, there is no immediate posterior separation. So as that patient grinds to the right and left, it actually increases muscle activity and loads the joint. And so it violates the concept of a perfected occlusion because there is no stable holding contacts on all the teeth and no immediate separation of the posterior teeth. And then there's some concerns with it. It's possible that you could get intrusion of the posterior teeth or super eruption of the anterior teeth. If that happens, it results in an anterior contact only, and then when the splint's not in the mouth, you get a distalization and driving back of the condyle into the retrodiscal tissue. A splint to use with caution is an anterior biplane. Here's an example of one called an NTI. It's a small device that has only anterior contact. It's basically just an anterior deprogrammer. Now, this device, when used in the short term, is wonderful because it does allow those posterior teeth not to make contact, and therefore you have shut down that excessive muscle activity. But it violates the concept of a perfected occlusion because there's no stable holding contacts on all teeth. And so what happens is sometimes patients will get such good relief from it, and it will cause relief if it's muscle, that they'll overuse it, they'll overwear it. And if they overuse it or overwear it, then we could have some concerns. You could get a possible intrusion of the anterior teeth or a super eruption of the posterior teeth. If that happens, then the anterior contact is lost in guidance. And then we'd have more posterior initial contact, causing more CO and MI discrepancies. However, though, we can take this idea and turn it into a positive. If you make Essex retainers on both arches and then you add the anterior component to either the top or the bottom, then you would have what we call a B splint or a bruxism splint. And so you have the advantages of the anterior pivoting, but you also keep the teeth stable because the coverage of the Essex does not allow for super eruption or intrusion to occur. Now, these are good splints to make after you have tried a traditional Michigan style. And on some people, that doesn't give enough relief because they tend to be clenchers. And on Michigan style, you have full contact everywhere. And so that if you're not moving out of full closure, then you'll be able to have strong elevator squeezing. And so with this device, there is no posterior contact, and it minimizes to the extent of the contraction that can occur. Again, managing forces. Here's another one. Sometimes people want to make a soft rubber appliance, and it also violates the concept of a perfected occlusion because the condyle is not allowed to stay in centric relation, and the contacts are not even. And it could even really increase muscle activity and incoordination rather than decrease muscle activity and incoordination. You know, that soft, spongy rubber cover in the back makes you want to kind of just chomp up and down. But I can think of a couple examples of times that this could have value. You might have a young patient come in that's erupting teeth, and mommy's brought that young patient in because one of those new permanent teeth is sore and they're having a toothache. Well, you know that it's probably just because it's interfering in this eruption pattern, and in time it'll just self-resolve and go away. But mommy was concerned and wants something done. And so if you make them a soft rubber on one of the arches, then there'll be a little bit of a pad and a cushion, and it'll make it heal a little quicker. Another time is I had a patient one time that had a very advanced periodontal problem, and wonderful middle-aged lady with trisomy 21, and we were sharing her between me and the periodontist, but her teeth had splayed so much, and we were trying to minimize future splaying, and there was not a line of draw that I could make a hardened splint on. So I would make her these, and I'd give her a couple each time she came in, and she'd go through them pretty quick. And at the same time, she didn't have any TMD problems or any muscle problems. And so it had value in a case like that. Another one is one called an anterior repositioning appliance. And this violates the concept of a perfected occlusion because the condyle can't stay in centric relation. It was more of a device in the past than it is in the present. And what it is, you'll see on that plastic that there's a ramp there. And when the patient closes, that mandible engages that ramp and it pulls that mandible forward in protrusion. And the idea behind it was that on some people that have repetitive popping or displacements, and even if it's just a lateral pole displacement, the idea is that you would protrude your jaw until you were far enough along that you had popped back on the disc. And then the idea is that you'd adjust the occlusion slowly and allow that condyle to go back with the idea that that disc would be recaptured. But in reality, though, did that disc actually become recaptured? Well, often not. So positioning the mandible forward could create circumstances, though, that the blood-engorged retrodiscal tissue could become fibrotic, thus preventing the condyle from completely seating in a centric relation, and therefore result in a loss of posterior occlusion. And finally, I'd like to finish up by just showing you a little bit about how the lab process works when a splint is made. And you'll see that this is base plate wax covering the teeth. And of course, it's put on articulator and it's mounted, and then it's closed into. And you'll see that the mandibular teeth close and indent into the wax. And often labs will leave this indentation into the finished product. Like this here, you get a close-up of the indentation, and you'll see that you'll get it back from the lab and you'll have both those indentations. And I think they do that to show you that they actually had occlusion. Well, the bad thing is they're not flat contacts. There's a vertical component to those indentations. And so the goal would be, after you've adjusted it, is that it ends up all flat. And so if you ever see a splint and somebody brings one in and you look at it and you see those indentations, well, you know it wasn't adjusted in the mouth. And that's common. That's common. A dentist will make a splint. They won't understand occlusion to the detail that we're teaching it to you. And that then they won't adjust it. And you'll see these indentations into the finished product.